Good afternoon, everybody. This is Dave Stapleton at Mathematica. I'm a senior fellow here and the director of Mathematica's Center for Studying Disability Policy. Welcome to our policy forum. It's on state initiatives that can help workers keep their jobs after an injury, illness, or disability. Mathematica's Center for Studying Disability Policy is celebrating its 10th anniversary this year. We conduct research that's intended to help improve disability policies and programs across the nation so that they can better meet the needs of all Americans with disabilities. And one way that we do that is through these disability policy forums and webinars. And this is approximately our 40th forum. I think we've lost count. So by way of background, here I am. So, today's webinar is going to address, it's motivated by the following problem. We know that about 1 million workers every year leave the labor force and enter the Social Security Disability Insurance Benefit Program because of a major medical problem. And we think that approximately 1 million others actually leave the labor force because of a medical problem, but don't quickly enter SSDI and they remain unemployed. And this is a major issue, of course, for workers, even if they get disability insurance, because their income goes down quite a lot. They and their families often end up living in poverty. And from the perspective of the economy and employers, we're losing a productive worker. Now, it's also pretty clear that an unknown number of those who follow this path, exiting the labor force, do so because they fall through the cracks in the support system. That is, if they had received evidence-based early intervention supports that would have helped them continue to work, they would have been successful in doing that. And disproportionate numbers of those who fall through the cracks seem to have low wages, low levels of education and skills, and they also seem to preponderantly work for medium-sized and small employers, but not all of them do. So, coordinate here, sorry. Got it. Research also makes it clear that as a country, as a nation, the United States underinvests in job retention services for such workers. Staying in the labor force, of course, benefits the workers. It also benefits their families, employers, states, and the federal government. And in fact, the private sector and states already do make some investments in job retention services. But overall, the incentives for doing that are misaligned, and there are many institutional barriers that we think result in suboptimal investments. And the biggest of these is that the federal programs in particular tilt incentives towards labor force exit and SSDI entry. And of course, once people get into SSDI, they'll eventually get into Medicare after another 2 years. And many of them also end up getting supplemental security income and Medicaid, which is a program which is financed roughly half by the federal government, roughly half by the states. SSDI and other federal programs would greatly benefit from providing better job retention services. And to give you an example, if a worker in his or her early 50s entered SSDI, it typically will end up costing the government, mostly the federal government, about $300,000 of benefits until that worker becomes eligible for retirement benefits. And there's also, of course, going to be lost revenues from income and payroll taxes. But unfortunately, right now, federal investments in job retention are minimal. And that's something that may change over the coming years, but it hasn't happened so far. So while we know that investment is low, it seems clear also that before there's a lot more public investment in job retention support, there first needs to be investment in developing and testing such supports. The good news is that we know a lot about services that work, that actually help workers stay in the labor force, but not necessarily targeted at the workers that are of greatest interest to us here, the workers that aren't getting them now, and not through programs that are largely supported by the public sector. So there are, in fact, many challenges that we need to learn about before and overcome in order to provide services in an effective way. We need to first figure out how to get to the right assistance to the right worker at the right time. We need to figure out how to cut across fragmentation in the support system. And we also need to avoid crowding out services that are already being provided by the private sector or by individuals, so that we don't just end up having the public program take on a lot of costs that are already services that are already being provided. So those things need to be studied, and states are actually an attractive laboratory for doing studies that would help us learn about what public programs could work and how they should be designed. And they would also, of course, as governments would benefit from the additional investments. They have some capabilities that they can use in order to help workers stay in the labor force. And also they can procure private capabilities. They know the private sector in their area. So one particular set of states, which has been proposed by the Social Security Advisory Board as especially attractive laboratories, is those states that have mandatory short-term disability insurance. And there's just 5 of them. The Social Security Advisory Board made this suggestion 5 years ago. Since then, nothing much has happened, but with those states. 10 years ago. And but that's in fact what we're looking into right now. So these states are interesting because it might be possible to identify most workers who are now falling through the cracks in the support system through their short-term disability claims data or through their workers' compensation claims data well in advance of the time when they apply for SSDI and when early intervention services are thought to do the most good. Now, what we can learn from these states can potentially be applied to other states as well, but as I said, little attention has been paid to this so far. Now, if you're from a state that's not one of these 5 states, and these 5 states are Hawaii, California, Rhode Island, New Jersey, and New York. That was 6. Did I put one in there that I shouldn't have? No. Anyway, if you're not from one of those states, it doesn't mean you should tune out from this webinar, because a lot of the things that these states could do, they could be done in other states too. Some are more difficult, some are less difficult. The other states won't have the advantages of having a short-term disability insurance infrastructure to work with, but they'll have other things that can be advantageous as well. So anyway, the speakers today, getting to them here, we're first going to hear from my colleague, David Mann, who's a senior researcher here at Mathematica, and he's going to report on the findings of a study that he did with Annette Bouvignier on the Rhode Island short-term disability insurance program. And then next we're going to hear from Yanni Ben Shalom, who is also a colleague here, senior researcher, and he's going to report on a study that he did with a couple colleagues on the short-term disability insurance program in the state of California, and also they were able to do a parallel analysis of the workers' compensation program in California. And then finally, I'm going to come back and talk about some of the options that we think are particularly of interest to states, and particularly states that have short-term disability insurance programs. And then we're going to finish up with comments from 2 experts, Teresa Bartlett from Sedgwick's Claims Management Services, and Teresa is going to provide her perspective from the private sector about what the implications of what you hear today for policy and the private sector in terms of helping workers return to work. And then we're going to hear from Jennifer Richard, who's now working as a consultant for the California Assembly Labor and Employment Committee. And she is particularly knowledgeable about the situation in California, having worked in work related to their public disability insurance program for a number of years. Before I turn it over to our first speaker, though, I am going to let Bryce, who's facilitating this, tell you about some background information you need to have in order to ask questions. At the end of all of the presentations, there will be hopefully 20 to 30 minutes to answer questions that you can contribute at any time during the session. So Bryce, why don't you go ahead?
Thanks, Dave. So at the bottom of your audience console are multiple application widgets that you can use. You can expand each widget by clicking on the maximize icon on the top right of the widget or by dragging the bottom right corner of the widget panel. If you have any questions for presenters during the webcast, you can click on the Q&A widget at the bottom and submit your questions there. We will address as many questions as possible during this session, but if a more detailed answer is needed or we run out of time, it will be answered later via email. We do capture all questions that are asked during the webcast. If you have any technical difficulties, please click on the Help widget. It has a question mark icon and covers common technical issues. However, you can also submit technical questions through the Q&A widget. Please note most technical issues can be resolved by pressing F5 or Command R on Macs to refresh your player console. A copy of today's slide deck and other resources are available in the Resource List widget indicated by the green file icon at the bottom of your screens. And finally, an on-demand version of this webcast will be available approximately 1 day after the webcast and can be accessed using the same audience link that you used to access today's live event. Now I'll pass it over back to Dave.
Yeah, so before I turn it over to David Mann, those of you who have attended our forums before know that we usually have a live room somewhere where we actually have an audience. This time we don't. So you're on the webinar and you are the audience, and we are going to pay a special attention to you. If you don't give us some good questions, we're not going to have good questions to answer. So please give it some thought, and we really encourage you to send questions in early so we can get started quickly when the speakers are done. Next, let's go to David Mann.
Okay, thank you, Dave. Good afternoon, everyone. Today I will be discussing a study that I recently conducted with Annette Bourbonniere. The study is an exploratory analysis of Rhode Island's Temporary Disability Insurance Program, or TDI. The study was funded by NIDLR as part of the Employment Policy and Measurement, RRTC. So what is the TDI program? The TDI program is a state-administered public insurance program. It provides income support to those insured by the program who experience a work-limiting condition acquired off the job. If a work-limiting condition was acquired on the job, then a benefit claim would go through workers' compensation, not TDI. The TDI program insures the vast majority of those who work in the state of Rhode Island, with the most notable exception being state workers. The maximum benefit duration is 30 weeks. The benefit covers about 60% of weekly earnings, subject to a minimum of $74 and a maximum of $770. A somewhat unique feature of TDI is its partial return to work, or PRTW benefit. The PRTW benefit was introduced as one of 6 major reforms that occurred in 2005 and 2006 to the program. The PRTW benefit allows TDI claimants to work up to a certain amount and still receive a partial TDI benefit. The partial benefit amount is calculated by taking the full weekly TDI benefit amount due to the claimant and then subtracting the claimant's weekly earnings. PRTW benefit duration is up to 8 weeks, and participation in this benefit is voluntary. So let me give you an overview of the study. We started by obtaining and reviewing TDI administrative data. We requested a broad set of variables because we initially didn't know what variables were available in TDI administrative data. After we received the data and examined it, we decided what research questions of interest we could answer with the data. We decided to examine how characteristics in the data were correlated with outcomes, such as the number of weeks claimants receive benefits, PRTW benefit use, and benefit receipt durations that exceed certain policy-relevant thresholds. The study is descriptive and examines correlations between baseline characteristics and outcomes. We are not estimating causal impacts for the TDI program or its PRTW benefit. To give you a preview of the results, we found that some characteristics were very predictive of claimant outcomes. We also found substantive differences in claimants based on their PRTW benefit utilization status. The TDI administrative data focus on what's needed to administer the program. As researchers, we'd love to have as much information about program participants as possible, but it is not surprising that when program data just focus on capturing what is needed to administer the program and have limited or no data on post-program outcomes. The analysis sample contains essentially all the claims made in 2011 to 2014, about 140,000. The 11 variables received from TDI's administrative data fall into 4 broad categories: demographics, claim information like benefit weeks and PRTW utilization, medical information including diagnosis and specialty of the treating provider, and pre-claim earnings, which are used to determine the TDI benefit amount. The data do not contain information on post-program outcomes, such as SSDI benefit receipt. This table is meant to give you a basic sense of the data by PRTW benefit receipt status. The TDI program allows maternity claims, but because our focus today and in the study is on claimants who could eventually claim long-term disability benefits, this table, as well as the analysis I describe on the following slides, excludes maternity claims. About 2/3 of TDI claimants receive a PRTW benefit at some point. There are multiple characteristic differences by PRTW benefit receipt status. Non-PRTW beneficiaries are substantially more likely to live in a household with earnings below the federal poverty level, or FPL, for a family of 4. They are also somewhat more likely to have a musculoskeletal or mental health-related condition. The gender composition did not vary much across groups. Our analysis has 4 outcomes of interest. First, we examined how the percentage of claimants receiving PRTW benefits is correlated with various characteristics. Next, we did a similar analysis, but for the average number of weeks claimants received TDI benefits. The other 2 outcomes we explored were TDI benefit duration measures that are policy relevant. The TDI program has a condition-specific at-risk benefit receipt threshold. Created using data from the Work Loss Data Institute, the at-risk thresholds are meant to capture a benefit receipt duration that exceeds 90% of claims for that condition. Exceeding the at-risk threshold triggers an administrative review of the claim. We also examined the percentage of claimants who received benefits for the maximum of 30 weeks because there is a substantial probability that at least some of those individuals will go on eventually to apply for SSDI benefits. In the summary of our main findings, we first found that there were substantive correlations between outcomes and certain characteristics. Perhaps unsurprisingly, the condition an individual had was correlated with various benefit duration measures. However, we also found that benefit duration was strongly correlated with the specialty of the diagnosing provider, even after controlling for the claimant's diagnosis. In addition, we found that outcomes were often correlated with federal poverty level, or FPL group. Interestingly, the patterns we saw for FPL did not always decrease or increase steadily with income. For example, the percentage with at-risk benefit weeks was lowest for the bottom and top FPL groups. Moving on to PRTW, we found that those who opted into PRTW benefits were different in various ways from those who did not choose PRTW benefits. PRTW benefit recipients tend to have higher earnings and benefit amounts than PRTW non-recipients. And even after adjusting for characteristics observable in the administrative data, PRTW benefit users spend relatively less time on average receiving TDI benefits. It follows then that PRTW benefit users are also relatively less likely than non-users to hit the at-risk threshold or maximum benefit week amount. Taken together, these findings suggest that those who choose to receive a PRTW benefit differ in meaningful ways than those who do not. So what does this all mean? What are the policy implications of our findings? First, they seem to suggest that there may be benefit to providing targeted early intervention services to TDI claimants. There are likely opportunities to use characteristics like diagnosis, provider specialty, or FPL group to identify TDI claimant groups who tend to have longer TDI benefit receipt durations and are therefore more likely to receive longer-term disability benefits, such as SSDI. Although it occurs in the middle of TDI benefit receipt, there may also be opportunities to use the choice to receive PRTW benefits to indicate that additional supports may or may not be needed. There may also be opportunities to provide helpful information to healthcare providers in order to promote better return-to-work outcomes. For instance, by giving providers a recovery time distribution of their patients' diagnoses, providers may be able to intervene quickly when benefit receipt exceeds key benchmarks. If TDI administrative data could be linked to other administrative data, then post-benefit receipt outcomes of TDI claimants could be more thoroughly examined. After we completed the study, we shared this study and our findings with Rhode Island state staff. We initially sent them a manuscript followed by a presentation that we gave at the Rhode Island State House in January. The state staff expressed interest in options to build on the PRTW benefit and deliver early intervention services that help TDI claimants return to work. Rhode Island is currently creating a working group to better understand the issue and explore policy options. This is the funding acknowledgement and the presentation disclaimer. Again, we thank NIDLR for their funding support, and I'd also like to thank Annette for collaborating with me on this project.
Okay, thank you, David. Next up is Yanni Bencholo. Yanni?
Hello, everyone. So my presentation is based on joint work with Frank Neuhauser from UC Berkeley, who I believe is listening in, and our own Dave Stapleton is here in the room. And I do, like before I begin, to thank SSA for their support to our Disability Research Consortium that we have with them, and the usual disclaimer applies. So in this study, we set out to examine the potential for using disability claims filed prior to SSDI application to identify workers with high risk of entering SSDI. And in the case of California, we were fortunate to do this using data from both the state disability insurance and the workers' compensation programs in California. And that means that we were able to cover most of California workers who experience a medical condition that leads to substantial work loss. So, as Dave mentioned, California is one of 5 U.S. states that mandate short-term disability insurance coverage for off-the-job medical conditions. And in contrast, workers' compensation in California is for on-the-job injury or illness, and that is mandated in the District of Columbia in all but one state, which is Texas. The two California programs differ in their purpose and administration and the nature and duration of the benefits, but they still have a lot in common. As you can see here in the table, SDI and workers' compensation cover almost identical sets of workers, except for public sector workers who are covered under workers' compensation, but they receive short-term disability benefits outside of SDI. And while workers' compensation is financed by employers, SDI is financed by a payroll tax on employees. Workers' compensation pays benefits for up to 2 years, whereas SDI pays them for no more than 1. And both base benefit amounts on prior earnings, but the replacement rate for workers' compensation is a bit higher. It's about 2/3 for workers' compensation and 55% for SDI. Unlike workers' compensation, SDI does not pay medical benefits, and that's an issue that I think Dave will touch on later on. So we obtained claims data from California's Employment Development Department, which administers the SDI program, and from the state's Department of Industrial Relations that administers the workers' compensation program. We have 1 more year of data for SDI than from workers' compensation, and we had to do a few things to make the data comparable. As David did, we exclude pregnancy claims from the SDI data, and from the workers' compensation data, we exclude the very short claims, those that last in less than 8 days. And finally, we also truncate the workers' compensation claims at 52 weeks, and we also drop any claims that didn't have all the information we needed. So what we end up with is an average of 366,000 SDI claims per year from 2007 to 2013, and an average of 62,000 workers' compensation claims from 2007 to 2012, And according to our estimates, these represent about 85% of all off-the-job short-term disability claims in California and 62% of all the workers' compensation claims in California. So in this study, we focused really on those claims that last for at least 12 months on these programs. We found that about 12.5% of SDI claims in a data, or 46.7 annually, reached that mark. In workers' compensation, about 18.6%, or 12,000, annually reached that mark. So that combined total, 58,000, when we compared that to SSA numbers, we found that that's close to 80% of the approximately 75,000 SSDI awards made to California workers annually during this period. Now, we can't observe which SDI or workers' compensation claimants actually entered SSDI without actually matching data to SSA data, but these comparable magnitudes imply that a large share of these long-term SDI and workers' compensation claims are followed by SSDI awards, and conversely, that a large share of SSDI awards are preceded by 12-month claims in one of these systems. Another very interesting finding is that the 12-month SDI and workers' compensation claims are similar to SSDI entrants in many ways. Perhaps the most important characteristic is diagnoses, which is shown on this slide. So if we look at the first diagnostic category, musculoskeletal conditions, we find that 35% of 12-month SDI claims and 46% of 12-month workers' compensation claims are for musculoskeletal illnesses, not including injuries. Across these two systems combined, the musculoskeletal illnesses account for 38% of the 12-month claims. Now, when we compare that to SSDI for 2014, 36% of awardees had a musculoskeletal disorder as a primary impairment, although these are national statistics, not just for California. When we look at psychiatric disorders, we find a largely similar picture. SDI and workers' compensation claims lasting 12 months are much less common for mental disorders, but overall they account for 13% of 12-month claims from the two programs combined, and that's quite similar to the 16% of primary impairments among 2014 SSDI awardees. We also find that, as with SSDI awardees, most claimants are from older age groups. The split by gender is just about 50-50, and pre-claim wages are predominantly in the middle or low wage ranges. Those are not shown in this figure here. So, thinking about early intervention, what we would really like is to be able to accurately predict these long-term claimants from information in the claim and the claim's outset. But that information is quite limited. We know the gender, the age, the medical diagnoses, and a few other things. And we find that such information can help predict the 12-month claims, but not as accurately as one would hope. So if you think about a program that, to be efficient, can only deliver services to SDI claimants in groups for which the probability of the claim is relatively high, and we're picking here just as a benchmark 40%, the passage of time combined with claim characteristics allows the program to deliver services to more and more claimants who benefit from them. And the figure here on this slide, the purpose of this figure is to illustrate that point. So if we follow 1,000 claimants, and let's start with SDI first, for every 1,000 SDI claims open on day 8, just one, we're able to just identify one that meets that threshold of a 40% chance of lasting for 12 months. Now, if we wait 3 months, we're left with 362 SDI claims that are still open, and 30% of those, or 108, meet the 40% criterion. If we do that exercise for workers' compensation, the gains of waiting are even larger. After 3 months, we end up with 193 of those 1,000 claims that have fall in that high-risk bucket. So if we translate this into annual numbers at a 3-month mark, targeting, if we had a program that targeted those with at least 40% chance of lasting 12 months, that would mean about 40,000 SDI claimants and about 12,000 workers' compensation claimants. So we believe that predictive capabilities we just presented need to be improved in order to efficiently provide services that are truly early. Some improvements can be gained through use of individual level claims data. We didn't have that for SDI. We think early administration of psychosocial or other screener questionnaires that are designed specifically for the purpose of predicting long-term outcomes, combined potentially with initial treatment information, could also lead to substantial improvements in the prediction of long durations. Another option for improving service efficiency is to provide the new services in a staged manner, start with minimal services, then ramp them up as evidence indicates that more intensive services are necessary. And all these three approaches can be combined. We know of a program in Washington State, there are Centers of Occupational Health and Education, which provides coordination and quality improvement services for the state's workers' compensation claimants. And Dave will tell you a bit more about that program shortly. So to wrap up, the California SDI and workers' compensation data revealed that most California SSDI entrants are long-term claimants from one of these two programs. We hear a lot of concern in the news and policy analysis about transfers from workers' compensation to SSDI. But I think an important point is that misses the large majority of high-risk cases which may never enter workers' compensation. If you think about the numbers here, we had 4 or 5 times as much SDI claimants who lasted for 12 months than workers' compensation claimants. And finally, while the data can be useful to predicting which claimants are likely to enter SSDI for purposes of delivering early interventions, more efficient targeting is likely to require the development and use of more information than what's available in just the initial claims data. Thank you.
Thank you, Yanni. And so my job is to just acquaint you a little bit with some of the options that we think states should be considering, particularly the states with temporary disability insurance, in thinking about how to move forward. Before I talk about those, I wanted, though, to briefly say a little bit more about the advantages of pilot testing some of these ideas in states with mandatory temporary disability insurance. And the first one is that they have an institutional framework that's already available, and I think that can be very valuable in developing a structure to do these sorts of things. I mean, there already is a structure, and they can build on that structure. The second thing is, I think, while in every state these sorts of interventions can be valuable to workers and their employers and to the state government itself, I think it's particularly obvious in states with short-term disability insurance because it's possible to see the number of workers that are in there and how many have long-term claims. And also, there are people that are paying for those claims already, and so they're going to potentially benefit from, all of those parties will potentially benefit from doing more with early intervention. And finally, is one that we've already mentioned, is that short-term disability benefits are at least the beginnings of an effort to identify workers who could benefit from these services. As Yanni has pointed out, and David, the information in claims is probably not by itself sufficient to do that very well, but there are other options that could be considered. Now, I don't want to minimize, though, the possibility that other states could get involved in doing these types of tests. They don't have the advantages that I just described, but I think many of them do have other advantages that are particular to their situation. So next I want to spend another, well actually, maybe I won't actually. I was going to spend another minute on the identification problem, but Yanni's actually done this quite well. I just want to reiterate one point that he made, and that is that there's this conflicting efficiency requirement. Right? We want to provide services as early as we can because we think, and the research shows, that that's when they're most likely to be productive and where there are opportunities to really help people. And just as an example, consider the management of pain, right? If somebody gets off on using too many opioids, they'll become addicted to opioids, and then it'll be very difficult much later to try to treat them for that addiction and get them into a more productive pain management regimen. Whereas if they can manage their opioid use carefully early on, they can be weaned of opioids and into other pain management methodologies early and be on the road to getting back to work early. So that's just an example. So it's really important to provide services early when possible, but we also want to avoid the provision of providing unneeded services. And so while we can wait a long time to see who really needs services, we've lost those opportunities, right? And so that's not a particularly attractive way to do it. So we'll come back to this point again towards the end of my talk. So I've got a laundry list of options, and I can only spend a little bit of time on some of them. But these options are ones that we think make sense. We've been looking at these for several years, actually. And in every case, there's some evidence about how well the option would work in some context, not necessarily the context that we would like to see it piloted in, but and the strength of the evidence varies. But there is evidence out there. We didn't just pull these out of thin air. And I'm going to focus my remarks on options that we think the states with temporary disability insurance could most profitably use, but there are others in here which could be very interesting to other states. And they range from the relatively simple, so the behavioral nudges, which is the first category on the list, to the relatively more expensive and the more complex. And the simple ones, you know, just doing something simple and inexpensive is worthwhile, even if it has relatively small impacts, whereas the more expensive and complex ones, you would only want to proceed with them if you, in fact, are pretty confident that they're going to have large impacts and be worth the investment. So going to the first category, the behavioral nudges, and here there are just, you know, probably 30, 40, or 50 that we could go through. The first set of them concerns duration guidelines, and I won't spend much time here because we know that both Rhode Island and California are already using the duration guidelines in their system, and David Mann already hinted at some of the ways that those could be used perhaps more productively. But that certainly is a whole area that would be productive to pursue. The next one concerns the idea of measuring lost work time as a quality metric. Let's see how well the providers who are serving our workers in this system are doing in terms of helping them get back to work. Keep track of that, report on it to the providers, find providers where return to work looks really problematic, find employers where return to work looks problematic, do things to follow up with them. The next one here is Claimants self-help information tools, and the particular idea that we keep coming back to here is doing something that would counter the messaging that I'm sure you've all heard in the media from lawyers, law firms who are really seeking to get a share of the benefits that the worker is entitled to, and you know, they always talk about how the worker is entitled to the benefits that they've been paying for, and that's certainly true. But the problem with that is it's a really one-sided view of what's in store for the worker, one that's to the benefit of the attorneys, and it neglects the fact that many of these workers, if they end up leaving the labor force and going on to SSDI and getting benefits, they're going to be much poorer than they are now, and they're going to lose the ability to really support themselves. And while that may look attractive initially, we know that many workers who go down this road are very unhappy once they get there, and many of them live in poverty. So that's kind of missed. And in addition, the attorneys aren't providing them with the ideas, the self-help tools, the connections that they could use to help stay in the labor force. So the next one, there are actually a whole set of things to do with physicians. And here I think particularly things that target physicians in areas where they may not have good information or where they are repeatedly using practices that are known to be problematic. Again, I would point to opioids as an example. There is a lot of work going on now to stem the opioid epidemic, and I think that work really has to start in physician offices when people come in with a condition that is causing them pain and they get inappropriate treatment and don't learn how to manage the pain using other types of drugs or other methods that would allow them to continue to function well and potentially get back to work. So there are a number of different ways that that could be done, and I'll mention some of those later on in context of something else. The next set of ideas has to do with incentives, and some of these are just cash incentives, straight out cash incentives. Rhode Island already has adopted this partial work subsidy, and you can look at that as an incentive to both the worker and the employer to help the worker get back to work more quickly than they otherwise would. I think Rhode Island should perhaps consider adding something to that, which I would call a commitment device, and I think this could work with any system. And the idea here is that the employer, the worker, and the providers would all develop a plan for the worker to get back to work, commit to following that plan, and there could be bonuses, incentives in there to pay, particularly the worker, for following the plan and also in getting back to work. But those bonuses could also potentially go to providers and to employers. There are also lots of services that could be provided to employers, and in fact, workers' compensation agencies provide all of these services in various amounts depending upon the states. But these include case-specific counseling and technical assistance, accommodation for subsidies for accommodation, provision of accommodations in the workplace, and all those things can be part of a successful return to work plan. For if the worker does not have a job-related injury, is not covered by workers' comp, they're not likely to get, the employer is not likely to have the benefit of services like that. So that's an area that something could be added to what the short-term disability insurance programs in these states are already doing. And by the way, the state VR agencies under WIOA have, they have authority to actually do some sorts of things for workers, for people who are workers who are still employed, that will, if they will help keep them to work. So it's a resource that states could draw on to try to get that done. There's a set of ideas or options that I call navigation and coaching. And the first group of these concerns various sorts of job retention coaching and counseling. And the idea here is to simply help workers who, after all, have very limited knowledge of the medical field, of services that are available to them, of their rights, etc. So these coaches would be trained professionals who would really help them understand what's available to them, work with them to make sure they're getting good medical care, getting other services that might be available, and also working with them in their discussions with the employer to help them get back to work. But the goal here is to help them get back to work primarily. And then the second type is what we call multi-party dialogues. And so this is just having a professional who's trained to do this, assemble the worker, the representatives of the employer, and of providers to talk, have a discussion to identify barriers to return to work, and also, to the extent that they do, develop sort of mutually acceptable approaches to overcoming those barriers. And this approach has been tested and found to be effective in other contexts. The final, there we go. The final set of ideas really has to do with more major restructuring of the service system, and in something called the SSDI Solutions Initiative, which was an effort by the Committee for Responsible Federal Government that occurred in 2015, developed a number of proposals that were really targeted at improving SSDI and preventing the exhaustion of the SSDI Trust Fund. And two of the proposals in there, one by ourselves and one by Jennifer Christian and some colleagues, were really methods of restructuring the service system that's available to workers when they first experience a medical problem. And in our idea, it was try to integrate the delivery of the types of early intervention services that we've been talking about into the path towards going to SSDI, so that workers would make sure that they knew what was available, had opportunities to use what was available, and in some cases were even required to use what's available before they apply for SSDI. And in fact, we saw this as something that could potentially be used to help the Social Security Administration determine who really should be eligible for SSDI and who shouldn't, something which they have a great deal of difficulty doing now. And the second approach, the Health and Work Services, really is kind of a new or a variant of public health services, community level system that's really focused on this problem, on helping workers with medical problems be productive and stay in the labor force. So they're going to be working with employers, health systems, and others in the community to make this happen. There's one particularly attractive model that could be incorporated in either one of these structured systems that we've come across, and I'll spend a couple minutes on that. And this is called the Centers on Occupational Health and Education, or COHE, and it was developed in the context of the Washington State Workers' Compensation System, which is a public system. They conducted an impressive pilot in the early 2000s, and their results were a 20% reduction in the number of claimants, workers' comp claimants, who were not working at 12 months. And that was actually over 30% for those with musculoskeletal conditions. There was also a 7% reduction in medical costs for workers' compensation. So here's savings from, for health care, on top of the much larger savings for wage costs, which would be the sorts of savings that would also be available to a short-term disability insurance program. And one thing that's not on the slide because it's too preliminary, but they found using preliminary data a 25% reduction in the entry of workers' comp claimants into SSDI over the following 8 years after their pilot. And so this was so successful that they now have in Washington 6 COHEs that cover the entire state, where workers, any part of the state, are able to use as part of their, when they have a workers' compensation claim. So to tell you a little bit more about the COHE model. So first of all, it starts with physicians being paid to file special reports. These are common in workers' compensation. So there's a report of accident, just letting the employer and the insurer know what's going on, but also a activity report, kind of forecasting what the expectations are for returning to work activity. And that's kind of standard. So, but one thing that they do with COHE is that they actually pay physicians when they fill these reports timely and completely. And the next thing is, I think the most important thing, is the health services coordinator. And this starts with something coming back to what Yanni had to say about how we figure out which services, which workers need to have services at the right time. So what they do is electronically monitor all of the records about a case as the case proceeds to look for problem flags. And they have screens in there, and they expect certain things to happen for each case. And when there's a sign of something going wrong, they reach out to a provider, a worker, or employer, usually a phone call first, to find out more about what's going on. This only happens in about 25% of the cases. The other cases get resolved without any intervention at all. And then when they do find a problem, they suggest simple solutions first, and then they escalate as is warranted. As the case proceeds, they have access to return to work specialists. They usually only work for the first 3 months of the claim, but if a claim is at the 3-month mark and there's good prospects for the worker still returning to work, they'll continue for the next 3 months as well. The COHEs also systematically are educating the various stakeholders about the best practices and new evidence on return to work. Again, I'll use opioids as an example. Washington State has done a number of things to change rules about opioid prescriptions, but the COHEs have played an important role in educating providers and making sure that they're using opioids appropriately. There are important caveats, though. I don't think a state short-term disability insurance program can easily go out and do what has been done in Washington workers' comp, and there are several things that are particularly favorable in workers' compensation. First of all, they had support from both employer and labor organization. Now I think that's something I actually think you can get in the short-term disability insurance program, because I think both employers and labor will benefit from improvements to the system. But the next thing is an advanced claims monitoring system, which they already had in place in workers' compensation, and it's harder to do outside of workers' compensation, in part because the short-term disability insurance program, they're not providing the health care. Also because of the HIPAA rules make it more difficult outside of workers' comp to talk about health conditions between the employer, the worker, and the provider. They are providing wage replacement insurance. That is, of course, offered in the short-term disability programs as well. But the crowning thing is that there's a single payer that's paying for all services, whether they're wage replacement or health care or vocational rehabilitation, and that's just not true outside of workers' compensation. So Jennifer, Christian, and I have looked pretty carefully at what it would take to replicate this outside of workers' compensation, and it is not easy, but we think the states that have the short-term disability insurance programs in place already have a big step up on doing this. So try to wrap things up here and get to our discussants. We think there are many attractive options for improving early intervention services, particularly in states with short-term disability insurance programs, but in other states as well. From a state's perspective, we think they have a Goldilocks problem, right? There's some options they may think, well, this is too small, it's not a big enough deal, it's not going to get enough for us. Others may be way too big. It's big structural change, we can't handle that. Which one is just right for our state? And I think that the answer to the Goldilocks question is dependent on the very particular circumstances of the states. I guess I'll repeat that states without mandatory PDI could conduct pilot tests, but we think they face more challenges than those that already have the state short-term disability programs. One big question I think the state should think about is, well, should it just go out and proceed on its own? Because there are benefits to the state and a lot of value there, but another option is, well, why not wait for some federal initiative? Because there is good reason to expect some major federal initiative to come along before too long. It's really hard to predict. And, with a fairly recent election, it's hard to, the players that are going to push this forward aren't in place right now. But there is a lot of interest at the federal level, and there is a recognition that to save the Social Security Disability Insurance Trust Fund in a way that's not going to harm a lot of workers, deny them benefits that they think they're entitled to now, that the best way to do that, the most attractive way to do that, is to offer these early intervention services. That's what could reduce the cost to the Social Security Disability Insurance Trust Fund more than anything else. And that trust fund is supposed to run out again in 2023. And in order to do something on the nature of early intervention, the federal government's going to have to start soon to test some of these options if they're going to use that as a way to address the problem before 2023. So that's it for me. And before we go on to our discussants, let me just remind you that we'd like you to submit questions via the Q&A panel on the screen now. Hopefully some of you have already done that. I haven't looked to see. But once our discussants have finished making their remarks, we're going to open up to a general Q&A for all the speakers, and we'll try to respond to those questions that are in there. So now let me welcome Teresa Bartlett. She's going to give her thoughts again. She's from Sedgwick about the research that we have just discussed and their implications from an industry perspective. And then we'll turn it over to Jennifer Richard and give her an opportunity to comment about the research implications from her own perspective, which is that of state programs and policymakers. Teresa and Jennifer are not in the same room with us. They're off by themselves somewhere, so we're just hoping technology is going to get them here really quick. Teresa?
Well, I'm here. Thank you very much, and thank you for allowing me to be a discussant today. I think the topic is very, very important and interesting. The first thing that I feel I have to comment on is the Social Security disability. And something that strikes me as a physician is we truly need to consider a paradigm shift in Social Security disability. And the reason that I see this is that medical conditions are generally very dynamic in nature. Conditions are treatable, new drugs to market, often people improve. But there is this mindset that once you get to Social Security disability, game over, you're on it for life, you're permanently disabled. And I think it would really benefit us as a country to think about it differently, to think about it as a temporary help for people that don't have a terminal illness. So that's just something that's very striking to me, that, you know, it's almost as if sometimes, I think you commented on this, David, that, you know, people get in the system and then they become impoverished and it becomes a way of life. And it's not the best way of life. And, you know, work can be very therapeutic, as we know. The second thing that I'd like to talk about is some of the screener tools that we discussed, and you mentioned opioids several times. So from a perspective of opioids, we do see the opportunity for physicians to use screening to predict whether or not someone is going to be addicted or going to have a prolonged recovery right up front. And unfortunately, through Sedgwick, we monitor this very closely, and we don't see a lot of physicians using these tools that are very simple and take very little time. So there's several. One would be the ORT, the Opioid Risk Assessment Tool. You know, a few questions, 5 questions, self-assessment, and it provides the physician with an ability to understand whether or not someone might be at risk for overdose, abuse, or, you know, long-term disability. The same with the SOAP tool, which is a screener and opioid assessment for patients in pain. Very simple tools that can be used, and yet we don't see these widely addressed in practice, even though the Center for Disease Control has asked physicians to address these risks and to understand them. So somehow we have to get more communication and education out to physicians and stress the importance of these screenings. And then the third comment that I'd like to make is one about, it continues on the pathway of screeners and understanding what you might be dealing with in terms of disability, is a study that has been around for a long time. It started in the 1990s, and it's called the Adverse Childhood Event Study. And what has been found in this study is that things that happen to you as a child are likely predictors of prolonged disability, later health problems, and adult risk behaviors. So they identified, I think it's about 10 scenarios that happen in early childhood: physical abuse, sexual abuse, emotional abuse, neglect, if a mother is being treated violently, if there's substance abuse, mental illness, if parents divorce, or if one of the members of the household is incarcerated. So this longitudinal study understands that when an individual becomes an adult, they are likely to have longer disability durations if something happens. They're likely to have more catastrophic thinking, and they're likely to respond differently, or maybe be more prone to wanting to be in a disability program because they're not very aware of the issues. So I would just, those are the things that come to mind as I listen to you and listen to what the different states are doing. And I think there's great potential from the medical perspective and from the payer perspective to ask physicians to really be more mindful of how they address these things.
Thank you, Jennifer. Thank you, Teresa. I'm sorry. That's very, very interesting. Now we'll go on to Jennifer. Jennifer, are you connected?
I am connected. Can you hear me?
That's great. That's terrific. Thank you.
Thank you very much for an opportunity to be a discussant in this conversation. I think it's critically important that we think about how we can best serve the needs of injured workers with our programs. One of the pieces that I feel is missing from this conversation is about what happens to a worker when they return from a period of disability to the workplace. Workers, unless they're covered by the FMLA or a state equivalent of that, don't necessarily have a right to return to their workplace. If they are covered by FMLA, that's only for a period of 3 months that they have a right to return after a period of disability to their previous employer. And then this larger issue of bias against employees with disabilities, whether it's a physical disability or a mental health disability. In California, we're seeing an increase in disability claims for depression. And I think there's an even greater stigma against employees who have mental health challenges, and that those issues of addressing both the workplace discrimination and stigma against individuals with disability are a challenge that must be addressed in order to ensure that workers have an opportunity to return to full and meaningful employment in the workplace. Some things to think about in this conversation about workers is, are we creating this incentive for workers to stay unemployed through this social insurance program of providing partial wage replacement during a period of disability through a temporary disability insurance program? There was a recent research done by UC Santa Barbara on the paid family leave program in California as part of a Department of Labor grant, and that research is actually on the Department of Labor's website still from October 2016 is when it was published. And most of that is focused on paid family leave utilization, but it also looks at paid family leave relative to the temporary disability insurance program in California. And one of the things that was really interesting to me was that we did not really see a change in utilization of the program associated with the market cycle. So that during the Great Depression or Great Recession, when you would have perhaps expected that market forces might have pushed people into greater utilization of the disability insurance program or perhaps the paid family leave program, we did not see that happen. Or perhaps you would have expected maybe that people would have felt, if they had a job, they wanted to hold on to it by any means necessary, and people didn't go on partial disability either neither effect happened. People used disability at the same rates regardless of the market cycle, and that was an interesting result, I thought. Here in California, we've had a policy intervention recently to the disability insurance program. In 2015, there was legislation that extended the disability benefit period to better address those who have chronic health conditions and make sure that it was easier for them to remain attached to the workplace when they were able to work. Our program in California, you have to serve a 1-week waiting period before you're eligible for benefits, so you have to suffer a full week of wage loss, and then you're able to receive benefits. But if you go back, it used to be that if you went back to work for 2 full weeks, that your benefit period closed, and you would have to, if you needed to go back out on disability leave, that you would have to suffer yet another full week of wage loss before you would be eligible. So that created a problem for people who are managing chronic health conditions. So they went out on for cancer treatment, and then they had ongoing chemo. They were well enough in between chemo appointments to return to work, but then suffered a period of shorter disability recovering from the chemotherapy, and then could return to work. The way the program had been structured with the waiting periods, incentivized workers from returning to work for what they could because they might end up having to suffer this wage loss without any wage replacement by the new benefit period opening up after just 2 weeks. This system expanded it, or this policy intervention in 2015 expanded the benefit period from 14 days to 60 days. So it's doing a two-month period. If you go back out of employment related to a disability, you won't have to reserve a 1-week waiting period. We've also been thinking a lot in California from a policy perspective about the financial impact of disability, and there has in 2018 we'll be seeing an increase in the temporary disability insurance benefit for both the disability insurance program for a worker's own disability and for when they're caring for a seriously ill family member or bonding with a child under the paid family leave program. And in 2018, the wage replacement rate will increase for the lowest wage workers who earn less than the average weekly wage to 70%, and for those workers who make more than the average weekly wage, the wage replacement will increase from 55 to 60%. That program will sunset in 2021 unless renewed by the legislature, and it'll be interesting to watch what that does with regards to utilization of the program, whether we see an increase or a decrease, or no change in the utilization of the program. I think that test, particularly in relationship to what data we now have about the Great Recession not affecting utilization, I'll be curious to see whether wage replacement affects utilization of the program with those increases. And there is a report that is requested back to the legislature about that programmatic change for review. One of the other factors that I think that folks should be thinking about with regards to policy interventions for those who go out on short-term disability and then transition into SSDI is sort of the stability of their homes and how that affects a worker's ability to remain attached to the workplace. That one of the biggest drivers of bankruptcy is having a medical health crisis, and if workers don't, if you end up suffering a bankruptcy because of wage loss and related healthcare costs, due to a health crisis, you become less stable, less able to, and that can affect your attachment to the workplace as well. So there may be a variety of complicated factors that are involved in leading somebody to become less attached to the workplace after a period of disability, both about what it means to them financially and their financial stability, what it means to them with regards to the social stigma associated with disability, and being able to explain to a future employer what that gap was in their work experience on their resume, and that we need to be thinking about all of these aspects as we look at interventions to help people remain attached to the workplace. Thank you very much.
Thank you, Jennifer. That's great. Very, very helpful. So now we're ready for Q&A, and we do have a couple of questions, but we're not brimming with questions out there yet, so I hope more will come.
Oh, we're closer to 10.
Sorry?
We're closer to 10 questions.
Oh, really? Then I'm not seeing them all for some reason.
Steve will be in charge.
Okay. Well, Steve, why don't you go do your thing?
Sure thing. So let me push this first question to the slide area. And this question comes from Frank Newhauser. Rhode Island appears to have 35,000 DI claims per year. California has 10 times as many claims at 350,000. But the California workforce is 35 times larger. Why the high claim rate in Rhode Island?
I think it's 3,500, not 35,000.
Yeah, it's 30. Over a 4-year period, we have 140,000. So if you divide that up, yeah, it's about 35,000 claims a year.
Oh, it is?
Oh, sorry. Oh, sorry.
I think Frank means
TDI or DI. Our study didn't look at DI claims. It only looked at TDI claims.
Well, Frank's number for California suggests his question is about TDI, where the 350,000 per year. And I think that's a good question. I don't know, David, if you're ready to answer that, because we haven't really done that comparison, between the states. I think a comparison between these two states and also some available statistics in the other states. I know that there's statistics in New Jersey, might provide some interesting information, but I don't know that we're ready to say anything about that right now.
I don't know if I have much to add to what Yanni just said. I think it is an interesting question and something that is worth looking at in the future. I don't know if the studies that we've conducted to date really get at that.
Yes. Frank, you need to send us the answer when you know it. We know you're Frank. All right, let's go on.
All right, this next question comes from Les Bowden. In the SSI workers' compensation study, have you linked the 12-month claims with SSDI data so you know whether they actually end up receiving SSDI benefits?
So, Les, the answer to that is no. Just to be clear, with the SDI data, we were not even able to get our hands on individual level data. We ended up with a compromise where they calculated statistics for us for a number of specific cells, about 600 cells. So really matching the data was out of the question. For the workers' compensation, we haven't really tried to go down that route yet. But we really wanted to highlight, we know that you've done a study, at least in one state, with matched data with workers' compensation, and we were really trying to fill the gap here with what can we say outside of workers' compensation, where really the majority of SSDI claimants do not go through workers' compensation. And yes, we did try to match, but for many reasons that did not happen. We're still trying to do that, in other states. But in this particular case, it just was not feasible.
Yeah, and just tacking onto that for the Rhode Island study, I think that being able to link the TDI administrative data to SSDI data would have allowed us to do a lot more in examining the outcomes of these individuals. We do know that Justine Hastings of Brown has been able to create a linked data set. Beyond that, we really don't know much about the details of what she's doing with it. It's her and a couple colleagues of hers that are working on this. So we are of interest. We're interested in what she finds when that comes out. But the study that we conducted for TDI only uses the TDI admin data and therefore doesn't link to SSDI benefit records.
Next question, Steve.
All right, this next question comes from Gary Bond, who asks, what is the Work Loss Data Institute?
That's a good question, and I wish I had Annette here. From what I understand, is a resource that basically trying to find the words. Gathers, collects, and publishes statistics on things like return to work duration for people with certain types of conditions. They may do broader things as well. That one thing that they do, it was the focus of why we brought them into our study, because the state of Rhode Island is using their data to describe the distributions of recovery times for conditions and to therefore create their at-risk measure.
Yeah, I was wondering, Teresa, if you know more, you'd be able to say a bit more about the Work Loss Data Institute. I mean, what I know is that they provide duration guidelines for certain conditions based on their database, and there are a few other...
Right. So companies like Sedgwick, and we're the largest third-party administrator of claims in the U.S. So companies like Sedgwick, as well as other third-party administrators, submit data, de-identified data to it's ODG, or Work Loss Data Institute, and what they do is they take this medical treatment data and return to work data and bump it up against evidence-based guidelines and actually create duration guidelines based on the Department of Labor statistics in terms of if you have light, medium, heavy jobs. And so depending on the type of work an individual does, it will give you, based on diagnosis and comorbidities, it will give you the likely duration of the claim based on clinical evidence. So, 70% of these people will return in 5 to 7 days, or a range like that, depending on the classification of the work. Does that help?
Yes, very much. Thank you.
And it is based on well over 10 million, claim cases, so it's a lot of research that goes into it.
And this is David Mann. One thing to add is the way we incorporated this into our study is that on the TDI administrative data, the diagnosis is given by ICD-9 and actually now by ICD-10 code. And then from those ICD-9 and ICD-10 codes, we're able to consult with information from the Work Loss Data Institute and find the threshold that would make an individual considered at risk given the condition they had.
Okay, yeah, I think we have...
Steve, we get that one.
Yeah, we have many more questions coming in too, and hopefully we can get to them, but let's move on to the next one, Steve.
All right, this next question is from John O'Neill, who asks, what role do you think medical rehabilitation hospitals can play in supporting return to work efforts?
Yeah, so that's a good question. I actually think they can play a lot of different roles. I will tell you that in the COHE system in Washington State that I talked about, one of the first COHEs was set up by a rehab hospital, and it still covers most of the western eastern Washington part of the state. So I think they just have a lot of expertise that could be very valuable in this area, even if it's used not to provide a lot of expensive services or rehab services per se, but rather just coordinating cases, which is mostly what these COHEs do. But aside from that, I think rehab hospitals are part of the service system that serves this population, and making sure that people who have serious medical problems and have to stop work because of those problems get helped on a path to going back to work, either because they're actually in the rehab hospital being served by them and getting the best practice services, or because they're outside of the rehab hospital but maybe they need to be getting some services. How you make sure that workers who aren't coming into the hospital or coming into the service system would actually get access to it. We could look through, and we can do this separately, John, about some of the ideas here, if you like, and and talk about what role the rehab hospitals could play. Do you want to offer anything else?
I have something to offer on that. I think that rehab hospitals, especially, I think about the work that Kessler specifically does. It's a question from John, and serving people with conditions like spinal cord injuries, traumatic brain injuries, and amputations. And I think that when people experience onset of that condition, often suddenly, they might not know what their return to work prospects are. So I think that educating these individuals, especially at the onset of their condition, about what they can do and the potential to go back to work, I think is important.
I will add one thing, that in Rhode Island, for example, in their workers' compensation program, there is a rehab institution called the Donnelly Center, and that helps many of those with occupational injuries to get back to work, but just because of the structural the structure of the programs in Rhode Island, those services are not available to the TDI population, and I think that's a question that Rhode Island has to figure out, but it's an institutional barrier for the rehab, that particular rehab service to be provided. Let's see. Let's move on to another question.
All right, this question is from Les Bowden, who asks, how were workers with workers' compensation PPD benefits treated in the SID workers' compensation study?
Yeah, so PPD, I believe, means permanent partial disability, and I wish Frank Neuhauser could answer that question. He analyzed the data for us, and I think because we focused on duration, I'm guessing those were either excluded or my best guess is that they were excluded from this analysis.
Really? Don't you think they would be there if they were off for the 12 months?
Yeah, well, in our table, I think there's a reason why we highlighted temporary disability benefits, but we can get back to Les after we...
Yeah, and Frank, I think you're still on. If you can send us, I don't know if you can send us a chat or not, maybe.
In the Q&A function, he probably can. Yeah. But let's move on to the next question, Steve, and we'll see if Frank responds to that question.
All right, this next question comes from Mark Mercier, who asks, when you measure providers using lost work time as a quality metric, do you adjust for the mix of business, such as type of employment or income group?
Not quite sure who that directed at. I think nothing that we did in our analysis did that. I guess a question for Teresa is whether that is usually done in the industry.
Well, I think the question was about your proposal to include a quality metric, and I think we think there's a lot that needs to be figured out. We haven't gone to that level of detail yet. But if Teresa, if you have anything to add on that particular...
Well, I think, in terms of when you look at duration guidelines in general, you do look at the type of business and the level of difficulty. The Department of Labor statistics, is it a light, is it an office job or a manufacturing job? And so in the industry, we do typically use duration as a quality metric and a benchmark, and we do it by segmentation of the type of job. So the answer is yes, as an industry, we do that.
So thanks, Teresa. Frank has responded to Les, and he says, we retained the cases with PPD, but we did not include the PPD benefits in the duration of disability time, only the temporary disability benefits figured in a duration calculation. So thanks, Frank, for responding to that question. And Steve, let's move on. It seems like we hopefully have time for 2 more questions.
This next question is from Carol Bellamy, who asks, when did the COHE begin in Washington State?
Sure. So I believe the pilot started in 2002, although that might have been a year where they were just sort of creating a COHE and getting the kinks out of it. And the test went on for a couple of years after that. And so since maybe 2006, it's expanded to the rest of the state.
Next question, Steve.
Okay, this next question is from Eliza Walker, who asks, can you comment on which types of early interventions are most feasible and or show the most promise for testing or implementing at a federal level?
Let me just back up to the last question. If people are more interested in the COHE there are various sources of information, and you can go to our website, the Center for Studying Disability Policy, and if you search there, search for my name, you'll find recent publications that are about COHE. So, and commenting on the types of early interventions that are most feasible and or show the most promise for testing or implementing at a federal or national level. I guess I'm not really sure how I should interpret federal or national level. We don't really think a national that a federal program can actually do early intervention very well. We think it needs to, the interventions themselves need to be delivered within local state service systems. And we see that as primarily the province of state programs in the private sector, usually working together. So if that was the intent, we don't really see any ideas that are great for a national program. However, the federal government can play a very important role in trying to encourage states and others to do early intervention. And if that was the intent, I think we know there is interest at the federal level in creating some sort of a multi-agency coordinating committee to have oversight over tests of early intervention and piloting and bringing systems up to scale. We think that would be a very useful thing to do at this point because the responsibility and the money that's involved here at the federal level is spread across lots of different agencies. In the context of that, though, I think we went over this long list of options, and we think all of these options are good ideas at some level. I think it's really hard to say which are the best ideas, but we've spent a lot of time talking about COHE, and if you're going to do something really major, structural, I think it's something around that nature that we'd like to see happen, or at least tested.
So, Steve, let's get to one last question, and I think it's actually for Teresa.
This is from Frank Newhouser, who asks, are there good studies that demonstrate that opioid screening questionnaires actually predict abuse and affect the outcome?
So, answer to that is the Center for Disease Control last year published opioid tools and guidelines for chronic opioid use, and they recommended a number of opioid screening tools, and they talked about it as in terms of a risk assessment. And so there are a number of studies, if you go to the CDC website, that are published in association with that. But really, it's an assessment of the risk so that the individual who may be at a higher risk is watched a little more carefully by the prescribing physician. So if drugs are lost or stolen or, bizarre things are happening, the physician is mindful that, this is a person at risk for abuse or overdose, and you just want to carefully manage that.
Okay, well, we're out of time. Let me first of all thank the speakers, and particularly our remote speakers, for, we've never even met them in person. This is quite remarkable, we think. Their contact information should be on the screen in front of you. Thanks, Vianney. So if you need to get in touch with any of them, you can do that. As we said at the outset, we do intend to answer all the questions that were submitted. I think what we don't have is a plan for how to send them out, but we will be posting the webinar on our own website in the next few days once we've done a little work with it. We could put a link to the answers to the questions there. We may also be able to send them out to the email list for everybody who's registered for this. So we'll get that done as soon as we can and make sure it is available to you. So again, thank you for participating today. Thanks to everybody else for all the help you did, and I hope to see you at the next webinar, or at least hear you.
Yeah, I just want to mention we have just a little mistake here for Jennifer Richard. We have actually her prior email, and she has recently moved to the Assembly of California. So, Steve, in the version that we put online of these slides, we should correct that email. Sorry about that, Jennifer.
Jennifer, if you'd like to provide your current email, you could do.
Absolutely. It's jennifer.richard@asm.ca.gov. So it's what's on the slide, except EDD's been replaced with ASM.
Excellent. Okay. Thank you. Sorry about that.
Thank you, everyone, and feel free to get in touch with us with any questions.
All right.